The children appearing in this film look normal. Yet, shortly after birth, they were to embark on several years of hospital treatment. They were all born with a condition which is believed to affect about 1 in 3,000 babies. Known as tracheoesophageal fistula and esophageal atresia, or TOF for short, it basically means they were unable to swallow. At the beginning of a pregnancy, when the fetus starts to develop, the trachea, which is the windpipe, and the esophagus, the food pipe, are a single tube. 4 weeks later, that tube normally divides into two, with the esophagus leading from the mouth to the stomach, while the trachea goes to the lungs. This division can sometimes be incomplete, giving rise to several variations of the TOF condition. Where atresia exists, the food pipe has separated to form an upper and lower segment. Nothing, not even saliva, can pass through. With fistula, there is a connection between a windpipe and the food pipe, which may allow stomach acid to enter the lungs and air to enter the stomach. Although the majority of TOF babies have esophageal atresia and tracheoesophageal fistula, some may only have one of these conditions. In a smaller percentage, there may be other problems known as the VARTA association. VARTA is an acronym for vertebrae, vascular system, anus, trachea, esophagus, renal system, and radius bone. One of these defects is imperforate anus, which means there is no opening to the back passage. Antenatal diagnosis of TOF is unusual, although the presence of polyhydramnios, where there is too much water in the womb, can arouse suspicion. An ultrasound can occasionally reveal the possibility of an atresia, but not a fistula. Esophageal problems should be diagnosed at birth. The baby cannot swallow its own saliva and turns blue. To confirm the suspected condition, a tube is passed into the esophagus. If it will not go down, it is likely the child has atresia. An X-ray with the tube in situ illustrates the diagnosis. The patient is then admitted to a children's hospital for an operation. In most cases, the surgeon can perform an anastomosis, where the fistula is divided and the two tubes of the esophagus are joined together. If the gap is too long, however, a join-up is not possible. So that the child can be nourished, a tube known as the gastrostomy is inserted through the tummy wall directly into the stomach. When a child is tube-fed, the esophagus can be opened in the neck to allow saliva to escape and sham feeding to take place. This opening is known as an esophagostomy. The purpose of sham feeding is to enable the child to associate the feeling of a full stomach with the sensation of sucking and swallowing. As an alternative to anastomosis, the stomach itself can be lifted into the chest cavity and joined to the upper esophagus in the neck.
Some of the surgical techniques being administered have been outlined, but a layperson will clearly find difficulty in assessing the merits of the various procedures, specifically the raising of the stomach into the chest cavity, a gastrostomy, and primary anastomosis. How is it decided which of these to use?
Perhaps we could take them in the reverse order. So if I could begin with primary anastomosis. When a child is born, the most frequent type of anomaly that a surgeon comes across is the one where there's an atresia and a fistula. And it's the fistula which the surgeon wants to deal with initially, because that's the cause of death if it is not dealt with. The fistula is ligated, and then the aim of the surgeon is to join the two ends of the esophagus together, and therefore a primary anastomosis is aimed for. If this is possible, then obviously we hope that the child will not need any further surgical procedures, and everything should enable the child to swallow normally. Therefore, the aim is always to achieve a primary anastomosis. Gastrostomy may be essential in some children, and previously a lot more children used to have a gastrostomy because the surgeons felt that if you did a gastrostomy, it would relieve the tension on a primary anastomosis where this was done. However, now we realize that a gastrostomy is not essential, and in some cases it may even cause reflux, which we want to avoid. If the anastomosis is tight, the surgeon might feel that the patient is better off being paralyzed for a few days while healing takes place and the anastomosis is sound, and therefore would rather avoid a gastrostomy but paralyze the patient. However, in some children a gastrostomy is essential, and that is in children who are born with esophageal atresia without the fistula, where the two ends are very wide apart. And when this is diagnosed on day 1 of life, the surgeon may opt just to do a gastrostomy so that we are able to feed the child, and when the child is a bit bigger, then we can decide on what the next stage of the operation is. Here we come to the third operation you mentioned, i.e. pulling the stomach up into the chest. If the child is born without sufficient length of esophagus, then there are several alternatives for a surgeon to use. And one of these is to take the stomach up so that the stomach can be joined to the upper part of the esophagus, enabling continuity so that when the child swallows, the food goes into the bowel. However, some surgeons opt to replace it with a segment of colon, which they take from the patient, and it's called a colon transplant. But this again depends on the choice of the surgeon.
Andrew was 8 months old, where a section of his bowel was removed and connected to the esophagus. This gives the advantage of using his own tissue, which is mobile and grows with him.
Some of the facts revealed in the film so far are clearly likely to disturb a new TOF parent, whom I suspect had never heard of the condition before becoming directly involved with it. Can you offer any comfort to parents who are still in the early stages of TOF?
Yes, and the majority of children with esophageal atresia and tracheoesophageal fistula do end up as normal adults. There are a lot of early problems, but nearly all of these can be solved surgically. Not everybody gets better because there are associated problems.
So we can say the success rate is encouraging?
Yes, very. For many units, it is years since a baby died of esophageal atresia or tracheoesophageal fistula and its direct complications. What the babies do die of, and this is quite a small percentage, are the associated other lesions, particularly kidney problems and heart problems.
Is permanent disability a possible result of TOF or OA?
Unfortunately, I have to say yes. There can be long-term problems in getting the gullet joined up, and with these there may be difficulty with swallowing, there may be permanent difficulty with swallowing, and some children have long-term difficulties with breathing. But it is important to remember that these are very uncommon nowadays.
Many TOF children have an instantly recognizable metallic barking cough, which echoes in the chest. It is known as the TOF cough, and is due to tracheomalacia. The windpipe is narrower and softer than normal, so producing this distressing sound. The joint in the gullet may narrow, causing a stricture which will lead to food sticking. This narrowing can be dilated by the surgeon. When food does stick, most children are able to immediately regurgitate it, Others may store it, causing a build-up, making the esophagus bulge and press on the windpipe. This causes the air supply to be cut off and places the child in danger. An immediate response is necessary.
It appears that the majority of TOF and OA babies have feeding problems when they grow. Are parents forewarned of these problems, and do they receive the support of dietitians regarding a balanced diet?
Perhaps surgeons have been a little remiss so far of warning parents of what they might expect after the initial operation is over. This is because we have been so concerned with survival. However, now that we have achieved very good results where survival is concerned, therefore we are not so concerned about the mortality, we are now paying attention to the morbidity. It is still very difficult to say which child is going to have swallowing troubles and who is not going to have swallowing troubles. However, there are some children who do develop stricture, and therefore we know that these are the children who are going to have problems. And we are now starting to advise parents on how to give these children more liquidized diets to begin with, and when they're older to make sure that they chew the food well, or perhaps cut up the food in smaller pieces. But as I said, we cannot tell beforehand which child is going to develop the problems, and therefore we have to go along as the follow-up continues. A dietitian is necessary because she may be able to advise in getting adequate amounts of nutrition into these patients. However, most of these children are able to absorb the food once, of course, it enters the stomach. So they shouldn't have problems with malabsorption. It is just a matter of stricture. It's a mechanical problem.
What are the advantages or disadvantages of entering the chest either vertically under the arm or horizontally across the chest?
There are no advantages or disadvantages as such. The standard approach to enter the chest, i.e. to do a thoracotomy, is through a horizontal approach. However, in the late 40s, the late Sir Dennis Brown, a surgeon at Great Ormond Street, found that entering the chest vertically gave a better cosmetic result, and therefore he started this, and a lot of surgeons have followed it, but not everyone opts to do that. The advantages are the same for both, i.e. that you get a very good view of the esophagus and of the fistula, therefore you can choose any. But once again, it depends on the surgeon's choice. Some prefer to do a horizontal and others prefer to do a vertical, merely because the advantage of a vertical is that when the child has the arm by the side, you can't see the scar at all.
Surgery for TOF became successful in the 1940s. The oldest surviving patients are approaching middle age.
I was immediately transferred to Great Ormond Street under the care of Mr. David Waterson. He warned my parents that the operation was touch and go, but added that I had a strong heart, and though they had just pioneered this type of operation, they had had one success before.
David Bland, a younger adult TOF, lets nothing stop him from enjoying life.
When I was 16, I applied to join the police force, passed the medical to get in, which is very strict medical. They accepted me. Not that I'm in the police force anymore, but there you go. Also, I do a hell of a lot of whitewater canoeing, rock climbing, this sort of thing. Very fit, active life. It's, as far as I'm concerned, I'm totally normal. And I'd just like to finish on one fairly big point. At no time in my life have I ever had to think, I can't do something I want to do because I've had this condition. I think that's the important thing.
Parents worry considerably in the early years of their child's life. They can feel dreadfully isolated.
It has been indicated that GPs know little, if anything, about TOF and OA. This must accentuate the desolation felt by new TOF parents. Do you believe that more GPs are now becoming acquainted with the condition?
This condition is not a very common condition, and therefore even the ordinary hospital doctors do not come across it all that often. However, more and more is now being known about this condition, and certainly the average textbooks of pediatrics, which every medical student now learns, has the mention of esophageal atresia and tracheoesophageal fistula, and also the general practitioner training scheme now incorporates part of their training in hospital on the pediatric wards, and therefore they're becoming more familiar with this condition. And of course, our communication with them is improving, discharge summaries, personal communications, and with the health visitors who now visit hospitals and homes, I certainly hope that better communications are being established.
The Tufts Group was formed in 1982 when two mothers, Linda Morris from Chesterfield and Julia Grimm from Wales, both wrote to the Voluntary Council for Handicapped Children at the same time. They were introduced to each other and were relieved to learn they were not alone in their dilemma. A letter to Health Visitor magazine brought together 15 more families. Further expansion led to the formation of Tufts, which for the first 7 years of its existence was run by Linda from her home.
I will put her name in the envelope with your information. Right. Yes, it really is absolutely fine. I'm sure this is going to do very well.
Tufts now has several hundred families nationwide and is in touch with similar parents' organisations abroad.
This map shows the distribution of our membership. The white ones represent ordinary members, and the orange ones show the members who are actually working for the group, the local coordinators, etc. And our aim is to establish a local branch in every area of the country.
Jean, although Andrew has now grown up somewhat, I feel sure that you must still have some very vivid memories of that lifestyle that a new Toff parent has got to come to terms with. Perhaps you can give some examples of the sort of things that would keep you awake at night.
Yes, I think like a new parent of all babies, you're always aware of the baby at the side of you, but more so with a child who's been in hospital and who has had operations or been ill. You continually watch the baby at night to see if the baby's breathing, to see if the baby is moving, looking for all little signs that perhaps aren't there. Andrew had a particularly bad cough, which is a Toff cough, and every time he coughed at night I got up to see if he was okay. Now this went on not just for days or weeks, but it went on for a very long time, for months, even years. I think like all Toff families, it creates a little bit of tension because you're up continually at night time, not just once but 2 or 3 times each night. This goes on for a long time, and I think you're very aware of the baby all the time. You don't relax, and there is the tension that is there all the time.
In 1989, it was decided more space was required, so the headquarters were moved to Nottingham.
Hello, Toffs. Hello, Denise. Yes. Oh, well, my name is Sue Dobbs, and I've got a son who's a Toff as well. Yes, he's 6 years old now. How old is your son? He's 1 year old. Ah, his name, Jonathan. Has he got many problems? Oh, that's good. But you'd like to find out more, yes. How did you find out about Toffs? Oh, she sounds smashing. Oh, it must be really nice to have a nice, caring health visitor like that.
The group aims to promote contact between Toff families and to share problems with solutions. They regard their most valuable function as being mutual support. In addition, they aim to provide understanding and friendship between parents who share the special problems of caring for Toff children.
Did you find that the hospital and social staff were able to provide you with all that you needed to know to enable you to care for Andrew adequately?
I think on the medical side, yes. But when we got home, we found that the main problems we had was with feeding. Not just when we brought him home first with the milk feeding, but as we progressed into mixed feeding, we found it very difficult, and we found that there were very very little advice from the hospital as to progress, what type of food to use, and so on. I think that this is why we decided to join TOFs as a group, to get the experience from other parents.
I've heard the term gastroesophageal reflux mentioned. Now, what exactly would this mean to a new TOF parent?
Well, gastroesophageal reflux is when the contents of the stomach come back up the esophagus. This usually happens after the baby has been fed. It doesn't happen in every case. Not all TOF babies have got this condition, but basically it's something that the hospital will help a new TOF family with. They usually advise the mum to prop the baby up when they are being fed, and perhaps for an hour or 2 hours after. In some extreme cases, the baby may have to sleep sitting up permanently. They also, at the hospital, will give the mum some medicines which will usually thicken the feed, which helps the feed then to stay in the stomach.
We've heard Miss Capilla say that all food has to be pureed. Is this very time-consuming?
It can be, because you have to make sure that the food has no lumps in, because if it does, even the tiniest lump can make the child choke.
TOFs publish a twice-yearly magazine called Chew, plus a regular newsletter. A national conference is held every 2 years.
As usual, she achieved something impossible. She trained at the Hospital for Sick Children, Great Ormond Street, and the training scheme was designed there so that you couldn't do it continuously in the hospital. You came...
Well, I'm greatly honoured to be here today to give this little talk to you, and it isn't a scientific talk. Now, of course, all this begins, as your little leaflet tells you. I found a leaflet outside telling you when the esophagus and the lungs and everything developed from the foregut up here, and this
TOFs raises funds towards research into the condition and to purchase specialist equipment for TOF families and hospitals.
Am I right in assuming that research into the cause of TOF and OA is being undertaken?
Yes, there's quite a lot of work being done, but it is a very difficult problem. This is a defect which arises very early in the development of the infant, and because of that, and because of the associated problems, we have not pinned down any obvious cause. Work is going on, but it looks as though it's going to be a long time before we come up with any clear answers or any probability that we can reduce the incidence of the condition.
TOFs became a registered charity in 1987 and is run by a network of TOF parents. This network forms a management council which is reviewed at the annual general meeting.
Sure. Right, thank you very much.
Many of the TOF children have now recovered or learnt to cope. Yet this doesn't deplete the relentless determination of the parents to expand the group and bring at least some relief to others who have just discovered that they have become TOF parents.